It's my first time in Egypt, and it's fantastic. Thank you for the invitation. So I choose one case of the last years because I changed my habits a bit. After that, it's a pretty scary case for me. It's just it starts normal with a young female, 18 years old. She's a bit short, and the BMI is a bit high, but just a pretty long history of repeating groin pain during all-day life. She's not that sporty. She's just doing normal things, walking around, doing her stuff, and had conservative treatment for many years. So she's coming in the outpatient clinic. We're doing our standard exam. The range of motion is pretty normal. Perhaps retrospectively, on the right side, there's a bit less internal rotation, but especially pain in end flexion and deep flexion with a positive fetter sign. So standard diagnostics, standard x-rays, nothing that special. Socket looks good for me. On the lower picture you see the pelvis AP. Of course it looks a bit retroverted, but it's an inlet view. LCE is normal. So normal, and you see this small irregularity on the ventrolateral head-neck junction. For me, it's not a cam; it's just a little reduced offset. And for the final test, we did an intra-articular infiltration test with a local anesthetic and a cortisone. And normally we send the patients away for a few weeks. Patient is coming back in the outpatient clinic and tells, I was very happy for 8 weeks. Now my pain is back again. Please do something. And we said, okay, we see a little bit of offset reduction ventrolateral. We go for a hip scope. These are the pictures of the hip scope. Synovial looks okay, no high-grade synovitis. Labrum looks pretty firm. We control the ventrolateral irregularity or offset reduction, burr it away, do a good burring there, and the central compartment shows no cartilage damage, no bigger lesion, no instability of the labrum. The only thing is perhaps a small separation of the contralateral area there, ventrolateral, but nothing special. LCF is okay. And the acetabular cartilage on the pubis, perhaps it gets a bit narrow, but not that an issue, hopefully. So these are the post-op or intraoperative fluoroscopies. We cannot see it that well, but I think we did a pretty good job. So patient is going home, standard post-op protocol. I think we set her on crutches for 4 weeks because the bone was a bit weak, but she's okay. 1 year later, she's coming back and tells, okay, 6 months it was okay, but now my pain is back again, and the standard protocol says, okay, we do a lower extremity torsion MRI. And what we see here, there are a lot of possibilities to measure torsion. I recommend always to measure it yourself, to check the papers, how they measured it, and we measured a reduced antiversion or a reduced anti-torsion of the femur. So, what to do now? We have made a good cam resection. Patient still has the same pain. So we did again the X-rays. We did again the MRIs. Everything okay. We did again an infiltration test with a local anesthetic. Checked her 20 minutes after the infiltration. Patient is pain-free. So what we consider then, we did a rotation and varistation intertrochanteric osteotomy. For me, this was pretty scary because the bone was a bit weak, and I pushed the blade in and I checked it on the X-ray, and it's far anterior. My entry point is not perfect, so we had to do a CT scan afterwards, but we saw okay. I was lucky. We did a bit of a varisation. This is direct post-operative, and on the lower right, it is after hardware removal, 12 months after it. Because we did a CT scan, we could control the rotational correction, and we saw, okay, we pushed it in the anti-torsion of the femur from -9 to +10 at the lower end of the normals. For now, at the moment, patient is doing fine. At the moment, patient is being happy. So the leg length is a bit shortened, but we gained a bit of internal rotation and lost nothing on the external. So this should be, hopefully she will stay good. So what have I changed in my daily habits? My physical exam changed a bit. I'm watching for the gait. I'm watching for possible rotation, irregularities. Where are the toes pointing? Where's the direction of the patella? And I put all young patients, I check the internal, external, in a supine and in a prone position. Diagnostics, actually at the moment I'm doing a lot of lower extremity torsion scans. If I'm not sure what is the problem, what I'm doing, what I want to do, if a hip scope is the right thing to do, I do a rotation scan. And with the intertrochanteric osteotomy, I now check about where my wire is, checking in 45 degrees flexion, and check the entry point, because when the blade is in and the bone is weak, that's it. Okay, thank you.